Hello learners, let us understand what do society, biology and psychology say about women's health. Gender has remained an inescapable phenomenon, serving as one of the most significant determining factors in an individual's life experiences. Both sexes exist in distinct social worlds characterized by widely divergent pressures, expectations and rewards. In many respects, there is no singular universal human experience. Rather, as this course explores, there is often only a bifurcated reality of men's experience versus women's experience. If the lives of men and women are so markedly different, psychology serves as a discipline that can address why these divergent paths exist. However, psychological inquiry has historically been most effective only when these gendered questions are prioritized as socially important. Whatever the current reality is, it is built upon a long history of popular mythology and biological evolution. According to data collected from the Centers for Disease Control 2013, there is a notably higher life expectancy for women in the United States than for men. Across various races and geographical locations, death rates remain relatively lower in women today. This stands in stark contrast to earlier human history. As noted by Gronsky and Schindler 2014, female mortality rates once exceeded those of men because they were so closely tied to the biological risks of childbirth. In the modern era, however, it is generally observed that men live shorter lives than women across the majority of industrialized nations. Health and healthcare policies do not exist in a vacuum. They operate under the scrutiny of the outside world and align with societal expectations that pressure individuals to conform to external norms. This course examines how women's health and healthcare requirements are both consequences and representation of patriarchal oppression. The normal psychological experience for many women has historically been one of the subordination, which frequently corresponds with the social desirability of femininity. This subordination builds upon the devaluation of feminine qualities, leading many women, particularly in Indian context, into a superficial, self-induced trap. When society suppresses female desires, women may begin to view the acknowledgement of their own health rights as hostile to their perceived social role and well-being. Women's health is a multifaceted construct encompassing reproductive health, mental health, and physical well-being. There are significant differentials in health status derived by social, economic, and environmental factors. Furthermore, there exists an intrinsic relationship between scientific claims and the day-to-day lived experiences of the self. As observed in the instances of menstruation and its impact on cognitive scientific assertions about female psychology, often align with self-cognition, the process through which women understand and internalize their own biological and social knowledge. The modern understanding of health has evolved from a narrow clinical focus to a holistic framework, beginning with the World Health Organization definition established in its 1948 Constitution. This landmark declaration shifted the global paradigm by asserting that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. By including social well-being, the WHO laid the groundwork for addressing the daughter discount, acknowledging that a woman's health inextricably linked to her status and safety within her community. This concept was further expanded by the Ottawa Charter of 1986, which reframed health not as an abstract objective of living, but as a dynamic resource for everyday life. This perspective emphasized that health is built upon social and personal resources as much as physical capacity. In the context of gendered malnutrition, this means that a girl's health is a functional asset that determines her ability to learn, work, and eventually navigate the biological demands of motherhood. When this resource is depleted through systemic neglect, the individual's capacity to manage the reproductive death is severely compromised. For the challenges of the 21st century, the Lesson 2009 proposed an even more resilient definition, identifying health as the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. This definition is particularly relevant to the hormonal cliff and reproductive debt frameworks developed in this course. It suggests that the true health parity is reached only when a woman possesses the physiological and psychological resilience to adapt to life's biological milestones. According to Vindhya 2007, this ability is self-managed is often the first thing lost under patriarchal oppression, making nutritional justice a prerequisite for the functional health defined by modern sciences. The history of Indian women's health documents a transformative journey from systemic negligence and limited access to a modern era of rising awareness and targeted interventions. Until the early 20th century, the health landscape for Indian women was dominated by staggering maternal and neonatal mortality rates and chronic malnutrition. During this period, women face a near total lack of accessibility to advanced healthcare services. A crisis compounded by the biological reproductive debt occurred through generations of neglect. During the late 19th and early 20th century, the health status of the female population was severely compromised by a cluster of exclusionary social factors. Practices such as female infanticide and child marriage, alongside restricted access to education and financial autonomy, created an environment where survival was a constant struggle. Clinical records from this era show a high prevalence of tuberculosis, severe anemia, and general malnutrition. As noted by Vindhya 2007, rigid social customs acted as a secondary barrier, preventing women from seeking quality care and further exacerbating the physical obstacles to their well-being. The 1970s marked a pivotal shift with the emergence of the women's health movement in India. This movement fundamentally reframed health as a matter of reproductive rights, gender discrimination, and equitable access. This advocacy paved the way for modern systemic shifts. Today, the Government of India, in collaboration with global health agencies, work continuously to implement transformative programs. A cornerstone of this effort is the National Rural Health Mission, which seeks to bring clinical services directly to the doorsteps of the most marginalized. According to Mishra 2014, these initiatives represent a critical step in dismantling the patriarchal structures that once dictated a woman's survival, moving the nation towards a modern of integrated and gender-neutral healthcare. The key aspect of women's reproductive health form a complex biological and social matrix that dictates a woman's lifelong well-being. At its core is sexual health, which encompasses the management of sexual relationships, the consistent use of contraception, and the proactive prevention of sexually transmitted infections. Closely linked is the broader domain of reproductive health, which focuses on the clinical conditions surrounding pregnancy, childbirth, and postnatal care, while also integrating the concepts of family planning and the management of the fertile life stage. The efficacy of these two domains relies entirely on accessing services, which includes the availability of safe, affordable contraception and high-quality prenatal care, as well as specialized healthcare services required for safe delivery and recovery. A woman's reproductive health status is influenced by a dynamic range of physiological lifestyle factors. Critically, biological fertility naturally decreases with age, a factor that intersects with individual behaviors such as diet, exercise, and substance use, specifically alcohol consumption and smoking. Furthermore, exposure to environmental toxins and the presence of underlying medical conditions such as polycystic ovarian syndrome or endometriosis can severely impair reproductive function and quality of life. As noted by Chakravarti et al. 2024, these clinical challenges are often exacerbated by structural barriers. Limited access to education, economic resources, and specialized healthcare services remains a significant determinant in the deterioration of reproductive health outcomes. According to Mishra 2014, bridging these gaps requires a move towards the reproductive sovereignty model, where women are empowered with both the knowledge and the agency to navigate these factors. By addressing the intersection of clinical conditions and social limitations, the health system can better support women through the high-stakes periods of pregnancy and the hormonal cliff of the postpartum phase. As stated by Vindhya 2007, ensuring that reproductive health is viewed through a lens of total well-being rather than just the absence of disease is essential for dismantling the historical daughter discount and achieving long-term health parity. Let's understand women's reproductive health first. So, reproductive health includes all concerns and attributes related to reproductive systems. It includes sexual health, pregnancy phases, childbirth, and family planning. Reproductive health is quite a crucial aspect of women's overall health and well-being. It impacts how they make their choices regarding their bodies and reproductive aspects. The next is the mental health of women, which encompasses their psychological well-being. Biological, social, and cultural factors influence it. Women are more likely to experience severe mental health conditions like depression, anxiety, and eating disorders. These conditions can severely influence their lifestyle and work-life balance. Family pressure and social expectations may further deteriorate their mental health conditions. The mental health of women is shaped by a unique intersection of biological vulnerabilities and systemic social pressures, beginning with an increased prevalence of certain mental health conditions linked to the life stage transitions. As noted by Gronsky and Schindler 2014, women are biologically predisposed to significant hormonal fluctuations during phases such as menstruation, pregnancy, and menopause. These hormonal shifts are frequently cited by researchers as primary triggers for deteriorating mental health, often manifesting as the hormonal cliff or postpartum depletion. When these biological triggers meet a lack of nutritional support, the resulting reproductive death can exacerbate clinical depression and anxiety, making these psychological milestones high-risk periods for psychological instability. Beyond biology, the influence of social factors play a definitive role in shaping the female psyche. Women statistically experience higher rates of poverty, systemic discrimination, and gender-based violence compared to men. Vindhya says that these external stressors act as chronic catalysts for mental health struggles, forcing women into the state of subordination, where their psychological well-being is sacrificed to maintain social desirability. This environment of constant vigilance and inequity often leads to the heavy mind, a culturally specific expression of the deep-stated psychological distress caused by patriarchal oppression. The burden of caregiving roles and their associated stress further compounds this risk, often leading to profound physical and emotional exhaustion. Many women act as a primary yet unpaid caregivers for children, the elderly, and the infirm, a role that significantly increases social isolation and chronic stress. As observed by Mishra 2014, this caregiver tax drains a woman's mental reserves, leaving her with little serve and return capacity for her own health or that of her children. Furthermore, there is a dangerous synergy between substance use and mental health. Women suffering from substance use disorders are significantly more likely to deal with recurring, co-occurring mental health issues, creating a cycle of dependency and psychological decline that is often difficult to break without gender-sensitive clinical interventions. Another important component to women's overall health is their physical health. Women's physical health encompasses a broad range of aspects, including their overall health and well-being. Reproductive and mental health are also a part of their overall physical health. They are more prone to physical health conditions related to breast cancer, heart disease, and osteoporosis. Uterine and ovarian issues such as endometriosis affect women only, of course, and pelvic pain is also more commonly observed in the female population. Gender has been significantly driving health outcomes for both men and women. It has been severely influencing how the disease starts, progresses, and how each gender responds to the treatment received. Beyond the biological differences, other contributing factors such as social norms, gender roles, and power dynamics have been triggering the health issues of women more stringently. Women accomplish a key role in their health status, access to healthcare, health-seeking behaviors, and overall well-being. Gender has its perspectives on the health status of both men and women. Let's take a look at some of the critical ones. Biological sex severely influences the health status of both men and women. Some pathways operate within the human body at genetic, cellular, and hormonal levels. The operating mechanisms of these pathways severely impact the susceptibility, progression, and treatment outcomes that each gender deal with. For example, men develop certain type of cancers while autoimmune disorders are more common in women. Certain gender norms may be harmful to society. Gender norms specifically related to masculinity negatively impact the health conditions of men. It discourages them from seeking medical care and support, promotes risky behaviors, and increases their stress levels. Similarly, the roles that are confined to women either by virtue of their family or biological differences place them in certain situations that increase their health risk. These are mostly related to childcare and household work. There are several social concerns revolving around the reproductive health status of women. It includes, but is not limited to, accessing healthcare, cultural expectations, and social pressure. These factors have been severely impacting the choices women make around their reproductive health and well-being. Such concerns also involve stigma, discrimination, and violence potential. All these factors together amalgamate to hinder women's accessibility to make informed decisions regarding their bodies and reproductive health concerns. Women, more specifically in rural or underserved areas, face significant challenges in accessing quality healthcare services. The major concerns are lack of transportation accessibility, resources, and awareness. The next thing that hinders them from thinking about their health is the high cost involved in these healthcare services. These barriers are especially crucial for those belonging to lower economic communities or living under precarious economic conditions. Social prejudices, cultural norms, and discrimination can further deter women's access to healthcare services. These factors also limit their ability to make informed decisions regarding their bodies if they do not align with social expectations. Sometimes insufficiency or lack of information about sexual and reproductive health concerns too can result in unintentional pregnancies, STIs, and other associated health concerns. Certain cultural norms, particularly those around motherhood, marriage, and women's roles, influence women's autonomous decisions around their bodies. Practices such as forced marriage and child marriages deny young girls their reproductive rights, resulting in severe health complications later. Acts like domestic violence and sexual abuse can also negatively impact their overall health and well-being. Suboptimal maternal care or lacking access to skilled birth attendants at the instance of giving birth are the next social concern. Inadequacy in emergency obstetric care services can further contribute to worsening the conditions around preventable maternal deaths. Forceful indulgence in unprotected sexual acts and lacking access to preventive healthcare services and treatments can make them prone to severe sexually transmitted diseases such as HIV. Women's biological health concerns vary and are wider in terms than those that men deal with. Understanding the gender-specific health concerns is essential for improving prevention, diagnostics, and healthcare outcomes. Besides the reproductive and mental health issues, women also deal with other physical health issues related to, first, cancers. Cervical, breast, and ovarian cancers are the most common cancer types among women. Second, heart diseases. Heart diseases are undoubtedly the leading cause of death across India in both genders. However, the disease manifests differently and to a greater extent among women than men. Women should be more specifically concerned about visible symptoms such as breath shortness, nausea, and weakness. Third, osteoporosis. Osteoporosis is the medical condition where the bone turns weak and break. This is most commonly observed among Indian women after the period of menopause. Fourth, autoimmune disorders. Autoimmune disorders such as rheumatoid arthritis, lupus, and multiple sclerosis are more common among women. Next, sexually transmitted diseases. Sexually transmitted diseases or STIs produce more severe complications among women. Some might even result in infertility and other pregnancy-related complications. And six, urinary tract infections. Women are more vulnerable to urinary tract infections following their anatomical differences. Women living in rural settings face a different set of health challenges than urban women. The primary reasons behind these differences are access to healthcare, factors related to socioeconomic status, and lifestyle preference. The chance of chronic disease are higher in rural women than in urban areas. They are also more vulnerable to poor physical stature following arduous labor. Urban women deal with healthcare accessibility and mental health issues. As the majority of urban women are indulged in working long hours, they are more prone to stress and anxiety. If we see rural women, they are more engaged in physically challenging atmospheres at home and in fields. They are more prone to developing chronic health concerns related to cancer, diabetes, health pressures, hypertension, strokes, and lung disorders. Moreover, rural settings have limited healthcare services provided and limited availability of specialized care. The transportation facilities are also not that good. They are more prone to depression resulting from social isolation and economic challenges. Whereas women residing in urban settings may experience more anxiety and stress levels related to their work-life balance pressures, financial constraints, and social pressures. They are more prone to issues such as diabetes, obesity, and hypertension. This majority follows sedentary lifestyle adaptations and unhealthy preferences and eating habits. While they do have better access to quality healthcare services, long waiting time and the cost of specialized healthcare services would add to their stress levels. Let us talk about the limited access of women to healthcare here in brief. Gender roles often restrict women's access to healthcare services. Such limitations stem from several factors ranging from their cultural norms, upbringing, economic constraints, and the imposed restrictions on the mobility and decision-making ability. Women are often asked to focus primarily on the domestic responsibilities such as childcare. This restriction can further limit their time and resources in seeking quality healthcare services. Gender-based discrimination results in biased access to healthcare services. Women often receive less attention than the men within the families. Controlling a wife or daughter's access to healthcare is the next significant barrier. Women usually lack financial resources if they are dependent on their families. This puts a restriction on their transportation to reach healthcare facilities, access medicines, or buy other medical supplies. Majorly, their literacy rates are low, hindering their ability to understand their rights to access healthcare information and advocate for themselves. The limited mobility of women following stringent social norms or lack of access to transportation can further add to the difficulties in their lives. Sometimes they may face difficulties in discussing their health concerns about sexually transmitted diseases or STIs. Many of them do not freely discuss even their mental health concerns, following the fear of judgment and social stigma. Limited or a total lack of healthcare services can put them at severe risk related to unintentional pregnancies. This can also make them prone to many sexually transmitted infections, maternal mortalities, and other preventable health complications. Barriers to healthcare services can result in them receiving delayed diagnostic support or treatment for severe health conditions, further worsening and deteriorating their outcomes. We know that the United Nations identifies and outlines 17 goals as Sustainable Development Goals or SDGs. These goals play a crucial role in transforming the way the world achieves its socio-economic growth. Here, SDG number 3, 5 and 10 majorly focus on the aspects of health, gender equality and inequality reduction. A study conducted by the All India Institute of Medical Sciences at their New Delhi campus reported that only 37% of women receive proper healthcare service access. This percentage was shocking compared to the 68% of men receiving them. This calls for the dire attention of the policy makers in India to streamline the accessibility of the severe healthcare services around so that no woman is deprived of a right to live healthy. Further, the World Health Organization believes that women's health depends on several factors, including social and governmental factors within healthcare dynamics. This framework interlinks several factors in concluding how accessible the system is to women. The research of Kamlapur and Reddy 2013 highlighted the relation between pessimistic sex proportions and poor nutritional conditions of women in the northern Indian states of Gujarat, Punjab, Haryana and Himachal Pradesh. The key reason behind this poor nutrition was identified as the socio-economic disparities. Several such literary works have been timely substantiating the deteriorating health status of Indian women. We'll be discussing this in detail in the subsequent modules. Thank you.